I now invite Dr. Ghana Ajoy for her talk on Phaco in patients with vitreoretinal interface abnormalities. Will a combined surgery be better? Dr. Ghana is a consultant vitreoretinal surgeon at Dr. Rani Menon's Eye Center.
Thank you, Dr. Divya. And thank you, KSOS, for giving me this opportunity. My topic today is Phaco emulsification in interface disorders, a retina perspective. So we all know vitreoretinal interface means it's a meeting plane of posterior vitreous cortex and the inner surface of the internal limiting membrane. And as soon as OCT became available, we were able to easily identify this interface and its important role in the pathogenesis of numerous conditions, retinal conditions. And what are they? They include vitreomacular traction, full thickness macular hole, lamellar macular hole, and epiretinal membranes. So the International Vitreomacular Traction Study Group, they developed an OCT-based anatomical classification for VMI. And they include vitreomacular adhesion, VMT, and full thickness macular hole. And these are the various, so the first one is a vitreomacular adhesion, a focal traction, a broad-based vitreomacular traction, and macular hole. So the question today is, phaco-vitrectomy, that is, do we combine phaco-emulsification and a pars plana vitrectomy in one sitting, or do we go for a sequential surgery? That is, do we do it before, or do we do it after the vitrectomy? This is our question. So the first combined emulsification with PPV was done in 1990, and the indications that we know, the clear indication is, if there is a significant cataract that deters PPV, that would be the real indication for going ahead with a combined surgery. Now, if it's a clear lens, you need not go ahead with the surgery, isn't it? There is no pathology, why go ahead? It was in 1997 that they said that you can do these two together and you will have a successful anatomical outcome and a marked improvement in visual acuity. So when we do a combined surgery, what are the advantages over a sequential procedure? So we have a shorter post-operative recovery time. We have a better visualization during vitrectomy, especially towards base dissection. There is a faster rehabilitation to the best final visual acuity. And of course, patient convenience, lesser cost, fewer surgeries, far more convenient. But when we look at the disadvantages, you have intra-op and post-operative problems that we face. So when we look at it, this is a straightforward small incision cataract surgery, and a long wound has been placed. And just to show that as we deliver the nucleus, the pupil becomes really small. So this again deals with how can we proceed with the surgery. It interferes with our visualization as well. So placing the intraocular, there is just one more thing that I want to note. The wound, as the wound is very stable, and after placing the intraocular lens, the pupil size has become even more smaller, isn't it? Now, placing the entries, the wound hasn't moved at all. There is no leak from the primary wound, and silicone oil removal has been done. And during this step, we need to do a lot of depression to see the rest of the retina. So this can induce even more post-operative inflammation. So in this case, there is a corneal opacity, and we end up scraping the corneal epithelium. So far more steps are needed for us to see the posterior segment in cases of combined procedures. Now, you can see in this case, almost half the cornea has been hydrated. Post phaco-emulsification. So look at this step, okay? Did you see that? So the iris has prolapsed when we are placing the our trocar cannula. This is because it is in line. We have placed it at the exact site of the corneal incision as well. So trying to put it back in, look at that, it has prolapsed again. So these are problems, and we are, our visualization is getting compromised further. We have sutured up the wound. So the view has become even more difficult for us, tried scraping. But again, this is a deep corneal edema, you're not going to do anything. Look at our view, it is very, very difficult for us to proceed with the surgery. So this, just look at the wound again. There's already an iris prolapse here. And this is because the air bubble behind the IOL is pushing up the lens. So in most of these cases, the thing to do is to suture up the corneal section no matter what. So as I said, the complications include intra-op, you faced a PC rupture or IOL sulcus. It takes longer to perform. You may require longer anesthesia. and there is an increased risk of inflammation after surgery. Now, after phacoemulsification after PPV, as madam has already described, you can have an unstable anterior chamber, there is lack of vitreous support, there is unstable zonules. So the need for multiple operations and a longer recovery time is a detriment to the patient. This provides a rationale for a combined procedure. But studies have shown that at 3 months, a meta-analysis as well, that there is no significant difference in anatomical or functional success, and efficacy and safety have been comparable with those of sequential surgery. This is one study, which is the effect of elective cataract extraction by phacoemulsification in eyes with VMT. The purpose was to evaluate the effect of cataract extraction by phacoemulsification in patients with pre-existing VMT. So one report that they found was, interestingly, that after even an uncomplicated cataract surgery, there were cases of VMT occurring within a few weeks. It resolved on its own, but the vision loss was not always reversible. They are not always symptomatic. For the symptomatic cases, a consensus has not been reached about which is the best treatment modality. So one other thing they noted was, in diabetic patients, they ended up having no vitreomacular traction release after phacoemulsification. In patients with stage 2 or stage 3 macular holes, they rarely close spontaneously. There is a natural course of progression from stage 2 to 3 or to 4. So patients in this study with stage 2 or 3 ended up having stage 4 macular hole. One thing we can say is that this just expedites the natural course of the condition. When we look at ERM, CME, or width of VMA, and the degree of nuclear sclerosis, this did not affect the chances of VMT release. However, this is a retrospective study with a very small sample size. Now, the most common complication in phakic cases is nuclear sclerosis or nuclear sclerotic cataract progression. What this means is combined group would have obviously a better result, and most patients with this cataract would lead to a cataract surgery within 2 years. Other complications are rare, but can occur, because when you have gone with a combined case, you may end up doing more dissection than is necessary and can inadvertently induce retinal breaks and retinal detachment. With current surgical practices, technical problems are rare, and the overall closure rate was not influenced by cataract extraction. So in the 90s, they said there were 3 factors that contribute to the opening of a post-surgically repaired macular hole. One was cataract surgery. But what it has recently been proved is that there is no late reopening of macular holes after cataract extraction. So if a good ILM peeling has been done, this leads to a stable macular hole closure. This was the AO's recommendation for VMT. And they didn't have anything really to say. They said if cataract is present, it is your decision. Do you want to go with a primary surgery or do you want to defer it? So to conclude, when everything goes well in a combined surgery, then that is what we want to do. Everything is done at the same sitting. But what about the second procedure? As we know, complications can occur during the second sitting as well. This is all. Vitreoretinal surgery is all about visualization. So let it not be a habit. Let us individualize this. With excellent anterior segment surgeons, we face very little problems with phaco-vitrectomy. Let's be an essentialist and just do enough and treat the main pathology. Thank you.
Thank you, ma'am, for that excellent